Think again. It's right, but partially.
Less frequent water.
Less frequent or more frequent?
Liquid.
Liquid is good, but see, take history from the patient. If your patient said, Doctor, I've got nocturia as well. So the thing is, it's better to drink in the daytime, but may not be better in the evening time. Otherwise, patient is like, Doctor, initially I was going 2 times in the night, now I'm going 5 times. What did you do with me? Right? So maybe in the daytime, yes, but in the evening may not be. But according to the history only, right? Any other general advice? And okay, UTI is common in male or female usually? Usually female. So you have got many female patients as well with UTI. So now, forget about this case. Just in general, I want to know the UTI general advices, what you would like to give. Patient might be male or female. Just in general, tell me the general advices. So number one, she said like drink plenty of water maybe in the daytime. Okay, what else?
Good hygiene.
Hygiene, yes. Maintain good hygiene. Yes. Any other thing?
Reduce caffeine.
Huh?
Reduce caffeine.
Yes, reduce tea, coffee, even smoking, alcohol. Definitely yes. Any other?
Cranberry juice.
Cranberry juice. Read on NHS what they say. They have written the cranberry juice is found to be useful, right? But it's not very much written properly in the NHS guidelines. But you can recommend. That's fine. Cranberry juice is helpful. Yes. Any other general advice?
Don't use public washroom.
Don't use public washroom. Oh, but they are there to use, isn't it?
Maybe
Just be very careful. I mean, if dire need, then only use that. Is something we can say. Okay, fine. Somebody mentioned wipe from front to back. For females, that's going to be very important because urethra is small, and the cause of UTI could be like if it's not like hygiene properly or something. Urination after intercourse. That's also very important. Yes.
Don't
Any?
try to hold it for very long.
Yes, please make sure that you don't hold your urine for a long time because that could be a reason as well. Any other?
Avoid bath.
Avoid bath. Then what should I do? Yes. Avoid bath. Take shower. You know, when I read this line on the guidelines, I was like, what else? What they want to know? Then I actually said, avoid in the bathtub. I mean, because the water is stagnant and that could be a source of infection. So shower is better. Fine. Any other general advice you would like to give?
Avoid
Huh?
bladder training.
Bladder training. Okay, but that is usually for incontinence. If patient has got any kind of incontinence, then we give them like the bladder training, you know, because they struggle to hold the urine. But okay, if patient has got incontinence, that can be there. You can explain things accordingly. Any other?
Avoid fragrance.
Avoid fragrance. Yeah, okay. I mean, that could be a source of infection as well. If you remember, like we discussed in bacterial vaginosis as well, any kind of like perfume products in out in or around your vagina, that could be a source of infection as well. Any other thing?
Tight clothing.
Uh,
Tight
yeah,
clothing.
avoid tight clothing as well. Cotton underwears, this is what you can wear, so that would be better as well, right? Another thing, if you've got elderly patient, I want you to look for another thing as well, and I've written it in the end actually in my slide. What do you have to do? You have to make sure I'm a safe doctor. So if your patient is 75 having UTI, we can manage UTI, not a big deal, but patient can go in something, confusion. Elderly patient having any infection, you need to be very, very, very careful. So what I want you to do in the history, I want you to take family history, whom you are living with, psychosocial history. If patient says, I'm living alone, what are you going to do? I'll keep the patient in the hospital. I won't let the patient go because I don't know patient can go in delirium anytime. And I can't tell it to my patient, if you get confused, come back to the hospital. Right? So what we need to do, we need to take a proper family history. If patient is living with someone, then what you can do, you can tell the patient that I can explain it to your son, I can explain it to your wife. In case you behave or in case you behave like differently or odd, then maybe they can bring you to the hospital. So that is something that we need to do. Right? So take history in the beginning itself. Right? So UTI treatment you can do, right? You know the antibiotics, you can give some symptomatic treatment as well for fever, for pain, for nausea, vomiting, you can give the treatment. And you can definitely give general advices as well. Then we have got BPH. So what is BPH? The patient has got enlarged prostate. How are you going to explain it to the patient? So what is prostate? Prostate is a walnut-shaped size gland where it is situated at the neck of the bladder. So you can explain it this way, so you can demonstrate this way. So what is this? This is bladder. Imagine this is bladder. That's a urethra tube connecting it to the bladder. So bladder and the tube connecting it. This walnut-shaped size gland situated at the neck of the bladder. So what happens as the age increases? The gland increases in size and put pressure here at the neck of the bladder. So what happened? That's why you struggle to pass urine. right? And it actually makes it a good medium for the bugs to grow because urine is collected in the bladder and you're not able to pass it completely. So what happens? It's a good medium for the bugs to grow, and that is the reason you may have UTI as well. So BPH can definitely lead to UTI. So if you explain this way, that would be better, right? So this is a bladder. That's a tube connecting it. This walnut-shaped size gland sit with the neck of the bladder. Age increases, gland increases in size, puts pressure here, and the urine gets collected here. You are not able to pass it properly. It makes it good medium for the bugs to grow, right? That's how we can explain. Treatment, BPH, tamsulosin, doctor, what is it? Can you simplify it for me, what it does?
Relaxes the muscles.
Yes, so what happens, this gland is putting pressure. What tamsulosin is gonna do? Relax. It's gonna relax the muscles at the neck of the bladder, yeah? What is finasteride?
Reduces
Yeah, it's gonna shrink the size of the gland. That's it, nothing else, that's the treatment, yeah? And if patient is any concern about cancer, I think you can answer, right? If there is no alarming sign symptom of cancer, you can say it's I can see you are worried, but the thing is, we're gonna do all these investigation, only then I'll be able to tell you what's happening, but most probably for me, it looks like enlarged prostate, less likely to be cancer, right? So that is something that you have to do in the exam, right? Okay. So, sometimes they can give a scenario. So, this scenario they give, so that is, I think, easily we can manage. Sometimes what happens, they might give it to you that patient is being brought to the hospital by his wife because of confusion. Patient was diagnosed with UTI 5 days ago. So, what happened here? Because of your UTI, patient went into delirium or confusion. So, how are you going to manage it? Sepsis is protocol, that so that can be done as well. So one station they can ask it in like a different way. Okay. Now let's discuss UTI, recurrent UTI. What is the definition of recurrent UTI? How many episodes you need? How many episodes?
3 times in a year.
3 times, 3 or more than 3, and 2 or more than 2 in 6 months. That's the traditional definition of UTI, right? So 2 or more than 2 in 6 months, and the 3 or more than that in 1 year. That is recurrent UTI. Causes? Why patient has? Yesterday in discussion, it was told not to do PSA in smooth prostate unless recurrent UTI. So it depends, we might consider doing, that's the case. And if patient, I'll go through PSA a bit more in detail, don't worry. What are the causes?
BPH.
Recurrent UTI, usually it's there in male or female. We'll see in females actually, right? So, what we can say in terms of causes is sexual intercourse, honeymoon cystitis, undertreated UTI. That's the most common cause actually. Like a patient is having UTI and we don't treat it properly. So that could be the reason that patient is getting the infection with the NK. Right. Atrophic urethritis, vaginitis because of post-menopause. So they will be having dryness in the vagina. So that could be the reason of UTI. We discussed that in menopause as well. Right. Abnormalities of the urinary tract, incomplete bladder emptying, contraception, maybe any foreign body obviously can be the reason. History of urinary tract surgery. Immunocompromised patient, obviously they'll be prone for infection only. Family history and of course personal hygiene. Right. So that would be the reason. Right. How are you going to investigate? So what do you think, what investigation can be done for the patient? The patient is coming to you with a recurrent UTI. Urine dipstick, okay, it shows infection. Culture can be done, isn't it? Urine culture, so you can give the antibiotics accordingly maybe. So that is culture. Ultrasound, if there is anatomical abnormalities if you have got. Remember this thing, see, in any station, what you are supposed to do, you have to see what is the red flag that I've got. So recurrent UTI, if it is with hematuria, make sure you investigate the patient for further investigation. Recurrent UTI with hematuria, right? Cystography and CT scan can be done according to like what is the history, what is the cause, what you give in the treatment. Have you seen any patient in your clinic having a recurrent UTI? What do you do in terms of treatment? Antibiotics, but we give long course of antibiotics. How many? Yeah, few months actually. That's it. It's a delayed prescription. We try not to, but when you have to give antibiotics, low dose antibiotics, but it's a long course with 6 months antibiotics you might be giving it to the patient, right? Obviously, if you found any cause, you treat that cause. Otherwise, sometimes you can't find any cause, so you have to give a long course of antibiotics, and of course, do symptomatic treatments, right? That would be really, really important. Okay. So let's discuss one more topic and then we'll start practicing few scenarios, right? Back pain. You know, there are two main topics in PLAB2 which are very difficult. One is headache, another is back pain. Why is it difficult? Because you'll find questions for sure from headache and the back pain. Don't take them lightly. We think, oh, it's easy. It is easy, but make sure we don't mess it up, right? So back pain, causes of back pain. There are hundreds of causes of back pain. We tried putting it in a mnemonic if you are a mnemonic person. Cavity. Cancer. Tell me which cancer can give you back pain. Prostate cancer we discussed, right? Huh? To be honest, any cancer, isn't it? Any cancer, what's going to happen? Cancer anywhere can go to your back. If it is thyroid cancer, if it is lung cancer, if it is breast cancer, if it is gastric cancer, abdominal colon cancer, kidney cancer, bladder cancer, prostate cancer, whatever you can think of, even bone cancer, I mean, that can be there in the back itself, isn't it? So any cancer can go to the back. So what question you can ask? Obviously, cancer question you can ask, and then you have to ask question for the systems as well. I mean, which cancer you're looking for? If you're looking for, say, bladder cancer, what question is going to be important? Hematuria. If you're looking for prostate cancer, you need to ask some BPH questions maybe. So if you're looking for lung cancer, you can ask for cough, hemoptysis. If you're looking for thyroid cancer, you can ask question for thyroid. So that is how you can narrow down your differentials. Can you name an autoimmune condition that can give me back pain?
Multiple myeloma.
Ankylosing spondylitis. What kind of pain I'm gonna have if I've got ankylosing spondylitis? There's something very specific about this pain.
Pain at rest.
Pain at rest. Okay. Yeah. So you know when patients wake up in the morning, they have got very bad pain, but as the day progresses, they feel better. Right? So they're taking rest, it's not going to improve their symptoms. But if they're doing something, some activity, that makes things better. To make the diagnosis of ankylosing spondylitis, for how long I should have this kind of pain? At least 3 months, at least, more than 3 months. If I'm having this pain like for 15 days, 20 days, you may not be able to make the diagnosis, right? So you need at least more than three months. Remember 3 criteria for ankylosing spondylitis. If you have all 3, it is ankylosing spondylitis. Number 1 is back pain, which is worse in the morning but gets better as the day progresses. And if it is for 3 months, that's first criteria. Number 2, anyone? Oh, you haven't seen the video. Huh? Number 2? Huh?
It improves with bending.
No. So number 2 is not for the pain, for ankylosing spondylitis, if you have got limited movement in the lumbar spine. That's number 2. Number 3 is limited chest expansion. It won't be that easy to do. So limited chest expansion. If you have got these 3, close your eyes, this is ankylosing spondylitis. But now question arises, why I'm going to ask chest expansion in a back pain? I may not ask that question. So there is another criteria that you need to know. So if you have all 3, ankylosing spondylitis. If you have got one of this, plus the back X-ray shows sacroiliitis, it is ankylosing spondylitis, right? So let's say these criteria again. So number 1 criteria is if you have got back pain, which is worse in the morning, but as the day progresses, it gets better. I mean, the rest is making things worse. It has to be for 3 months, more than 3 months. That's number 1. Number 2 is limited movement in the lumbar spine. Number 3 is limited chest expansion. All 3, ankylosing spondylitis. One of this, for example, patient has given you only back pain, rest of the things is giving negative. But later on, when you ask for the back X-ray, what examiner gave you? Sacroiliitis. What it is? Ankylosing spondylitis. Coming quite often, be careful, don't miss it. Right? Okay, so treatment-wise, what you have for ankylosing spondylitis? Steroid can be given, yes. Painkillers, obviously, and then DMARDs and all can be given. Biological treatment and all can be done for the patient. Okay. Vascular causes. Can you name a vascular cause? Vascular cause that can give back pain.
Aortic.
Huh?
Abdominal.
Yeah. AAA, abdominal aortic aneurysm. So that can give back pain to the patient. Right, okay. Can you tell me what will be specific about this back pain? Any specific word we might hear from the patient?
Tearing.
Tearing kind of pain. So that patient might say it's a tearing kind of pain. Who will be your patient, male or female?
Male.
Male, elderly, young? Elderly male you will have as your patient. Let me show you this slide as well. Abdominal aortic aneurysm. Who are at risk? Man aged more than 65 years of age, smokers, hypertension, and familial history. They are at risk of developing AAA, abdominal aortic aneurysm. That's why what we have got a screening program as well for AAA. It's done only once. Usually screening what happen like you may see like it's done every few years, like cervical screening, how often you do, like every 3 years and then every 5 years you do. But this is done only once in lifetime. In England, screening for AAA is offered to men during the year they turn 65. This can help spot a swelling in the aorta early on and it can be treated accordingly, right? So back pain, it's a tearing kind of pain. Any other symptom that I can get from the patient? Back pain, yes. Anything else? No, doctor. What are the questions you think I should ask? Hypertension, I'll ask in the past medical history. Smoking, I'll cover in lifestyle history. Anything else? Any mass. So sometimes patient might give like I've got pulsatile mass in the tongue, but sometimes patient might not have appreciated that as well, right? So later on, when you do examination, I would definitely want you to ask for abdominal examination as well, because some examiners they are very strict. They will give you only the finding which you will ask for. So I would like you to say general physical, vitals, back, abdominal examination as well, if you have got AAA in your mind. Yeah. So, what's the treatment for AAA? How are you going to treat AAA? Number one is, of course, have a control on hypertension, control smoking as well, because these are the risk factors. But what else is? What's the main treatment plan? Come on. I thought you have already read it, no? Depends on the size. What we're going to do, we're going to do ultrasound. If the size is big, you don't need to remember every like particular centimeter and all. If the size is big, what's the treatment? Surgery. And the size is small, what happens? We keep on doing the ultrasound scan at regular intervals. That's it. If you want to go a bit more in detail, so small AAA, 3 centimeter to 4.4, you're going to do ultrasound scan every year. If it is 4.5 to 5.4, you're going to do ultrasound scan every 3 months. If it is more than that, go for surgery. Right? That is the thing. Okay. Let's come back to back pain. So cancer, so many cancers we discuss. Autoimmune condition, AS for example, vascular is like your AAA that can give us back pain. Infections, can you name any infection that can be the reason of back pain?
UTI, pyelonephritis, renal
UTI
calculation.
we discuss what isn't it? UTI can give us back pain. Pyelonephritis I mean can give us back pain. Huh?
Discitis.
This? Discitis, so infection in the disc itself, fine. Okay.
TB
Okay.
spine.
Right. Even a stone we can look for, isn't it? The stone, I mean, of course, the pain is gonna be here, but then it can come to the groin as well. Loin to groin, that is what we can see. Have anybody experienced kidney stone pain? No. Have you seen a patient? Yeah, you must have seen. How it is? It's really bad, isn't it? Really bad pain. Patient is gonna be in too much of pain. Okay, let's discuss a bit more about the stone as well. Okay, you tell me first of all causes. Why a person develops kidney stone? Risk factors, if you can name few.
Dehydration.
Less intake of water, number one, good.
Like calcium.
Calcium, yeah. I mean, usually you see like it's young patient, they have this kidney stone. So the reason could be they are consuming like say too much of proteins in their diet, calcium supplements and all. Gym people they might be taking. That could be the reason as well. Any other? Metabolic, yeah. Which medical condition you're looking for? Gout. Okay. Yes. Okay. Good one. Let me show you this slide actually. Gout also good. Maybe patient have hyperparathyroidism as well. Depending, because we have got different kinds of kidney stone. All these things are there in your book as well. Don't worry. Right. So calcium stone. Mainly the stones that we have is calcium stone, right? Could be because of any hyperparathyroidism and all, any metabolic problem if you're looking for. If patient is having recurrent UTI, that could be the reason as well. That would give rise to struvite stone, for example. Uric acid stone can also be there. Rarely you might see cysteine, but mainly these three. But calcium stone is going to be the maximum. Causes, risk factor, we discussed some, like not drinking enough water. Second, like we said, like taking supplements, protein, calcium supplements.